right, maybe we'll give a minute or two for people to join in.
Good.
So, but yeah, welcome to the Extracorporeal Hour. Happy Friday. Um, I'm very happy today that we have a special guest. I think the paper came in the JVIM like a month or two ago, and I was really happy to see a paper on TPE in a neurologic condition, um, and especially a case series and not just a case report. So I thought that having one of the author as a special guest of the Extracorporeal Hour would be awesome, so he can uh, present his work, maybe go a little bit more in detail on the TPE protocol, because I was a little frustrated by the small paragraph in the paper. And that then we could open the floor for discussion, and maybe other people can report their experience with similar cases, and maybe we can discuss like how we can improve the outcome in these dogs with different TPE protocols or over treatment modalities. So, for those who don't know me, I'm Cedric Dufayet. I'm the head of the Extracorporeal program in San Diego for UC Davis, and I'm one of the two co-hosts of the Extracorporeal Hour. So Jethro is currently wearing a mask because he's doing hemoperfusion on a calf.
Yeah. Good morning,
So,
everybody. Thanks for joining us. As Cedric said, I run our extracorporeal unit out here at Cornell, and these sessions are, as always, a place for us all to come and learn and share experiences with each other as we're building the evidence base for how we do what we do, and share great outcomes, which is going to be a great, I think, topic of the discussion here today. So thanks for joining, and I'll turn it back over to Cedric. Thanks.
yeah, so in order not to make any mistake or anything like that, I'm going to let Dr. Alessio Vigani introduce himself. He's a critical care deep, like I think diplomate from both the American and European college. So please, Alessio, introduce yourself, and then you can share your screen, and we can get into your paper.
Amazing. Thank you so much, Cedric. Thank you so much, Jethro, for inviting me. Thank you, everybody, for showing up today. I hope to be up to the task. And I was invited because we recently published this case series on the use of TPE in polyradiculoneuritis here from the University of Zurich, which is where I work now as tenure faculty and director of the extracorporeal unit, the emergency, and the critical care department. So that is my current position. I worked as a faculty, a clinical faculty at North Carolina State University before moving to Zurich for 5 years, from 2015 until 2019. And before that, I did a residency, two consecutive residencies, one in anesthesia and analgesia, followed by one in emergency and critical care, during which I integrated the fellowship in hemodialysis with Karsten Bent before he left. And then before the residency, I was at Ohio State University for my rotating internship. And before that, I graduated and did a PhD at the University of Milan. And that's about me, at least professionally. Hey, professionally, that's, I guess, all that matters. So I'm going to try to share my screen. I need to allow this. I need to say that, share, put this one, and play. You see my slide, or what do you see?
Yeah, we see your slides, but with slide 1 of 50 on top and the clock.
Okay, so I need to
It's not
change.
like full screen. Yeah.
Yeah. I need to change screen then. Okay, I need to go to the full screen. Pa, 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 pa. Um, share. Share settings. Oh, share, we go with this one. Share this one.
Yeah, looks good.
Working?
Yeah. Oh, now we're back to your desktop.
How
There
about
we go.
now?
Yeah,
Yes.
all good.
Awesome. So, a quick disclaimer is one of my very first, actually, it's not the first, it's the third time I participate to these rounds. And the simple reason is that the time is very bad for a Friday evening in ER. So it's not always possible to join, but I'll also try my best from now on to participate as well as an attendee. But yeah, so the title of the study that we published is the clinical response to acute idiopathic polyradiculoneuritis. And we treated over a course of about a year and a half, 4 cases for which we had pretty solid background confirming the diagnosis and excluding the possibility of most likely alternative differentials. So the reference is listed here for the publication. What do I like of the paper is the fact that it's short. So it gives a message, but it doesn't linger too much on things that a case series should not linger on. But thankfully, the reviewers did not ask to do a review paper on polyradiculoneuritis out of a case series. That made me very happy. The part that I don't like is the fact that the original version of this paper was 80% based on the TPE protocol that we did. And the reviewers were obviously neurologists, and they were like, oh, very nice, but can you talk more about the idiopathic polyradiculoneuritis diagnostics? And that made me pretty sad. I tried to justify the reason why we extensively covered the details of the TPE protocol, but now they really wanted more material, and the word count also is very strict now for case series in a JVIM, so we had to cut everything out. But the supplemental material should have a better detail on the protocol itself in the online version of the paper. So at least we were able to put some more in there. But unfortunately, as I said, for the article, not many information were allowed to be left, which, as I said, is probably the saddest part of this publication. I don't want to be too annoying about details on the TPE regarding how it started and so on. Everybody knows that it means to take away by force. And that's what we try to do when we want to remove something that we don't like using the machine. And it's been more than 100 years that clinically has been used. We started with the same technique. And in this, I kind of put some of the things that I wrote. We started with the first version, poor man manual TPE, going to the obviously modern application of centrifugal and membrane-based TPE. I put this picture simply because on the right side, the one with the green band, is my newest toy, is a double filtration plasmapheresis device, which I put a couple of slides later if you guys are interested. But that is the latest toy that I got access to. Regarding human indications of TPE, the categorization or the classification of the diseases is based on proven efficacy of clinical results. So to become a category 1, TPE has to become equivalent or superior to gold standard therapy. Category 2 may help, meaning is supportive, and there's no indication that might affect negatively the outcome. Category 3, as an indication, represents a situation where there are only case reports or case series, which is what I did. And then category 4 is actually the situation where TPE is not recommended because the risk of side effect or deterioration or clinical deterioration make the therapy inadequate to be applied in a clinical setting. So for class 1 disorder, and I skipped some stuff regarding TPE, but for neurological disorder, class 1, absolute class 1, for which there's no further debate whether is an effective therapy that is equivalent or superior to any other intervention up to this moment being applied clinically. Acute polyneuropathy, polyradiculoneuritis, and myasthenia gravis, particularly in a fulminant form, are the kind of primary target. For the both diseases are immune mediated, as we well know. For myasthenia gravis, now we had 40 years of knowledge about the immune mediated nature. For polyradiculoneuritis or acute inflammatory demyelinating polyradiculoneuropathy, the situation is slightly different. Why? Because in veterinary patients, particularly dogs, if we want to talk about one specific species, the distinction between different form of immune-mediated polyradiculoneuropathy is not so detailed as it is in human yet. As you will see in a slide later, there is evidence that antibodies are involved. Anti-ganglioside antibodies are involved in canine patient with undefined polyradiculoneuritis, but a discrimination to the degree of Guillain-Barré-like syndrome versus other form of neuropathy where complement or not is involved is something that we are still not in a situation of being able to discriminate clinically in canine patients. I speak canine patient because yes, polyradiculoneuropathy is described in cats. I never seen one or treated one, so I speak more about the dogs simply because that's the patients that we treated in the paper. Then if we want to have a discussion about the kitty cats, we can. I'm not a neurologist, so I can add very little. When they can't breathe, I intubate them. So that's pretty easy for me. But the bottom line is polyradiculoneuritis in general, particularly when is acutely progressive, is a primary indication class 1 for use of TPE in a human patient, just like fulminant form of myasthenia gravis or relapse of clinical signs of myasthenia gravis in a patient during treatment. This is the poor man quick neuro exam that we do in the ER to say, yep, probably is a generalized peripheral nervous system involvement. And at that point, we start the workup. So normally this is the stage where I end my diagnostics. I get to the point of generalized peripheral nervous system disease. Then neurology gets involved. And that's exactly what happened in the cases that you find in the manuscript. They were patients that were either referred by neurologists for the treatment where the diagnosis was already made by the neurologist, or they were presented with clinical signs suggestive of generalized peripheral flaccid neuropathy, so peripheral nervous system neuropathy, and then following diagnostics by exclusion, basically, the diagnosis is made of immune-mediated polyradiculoneuritis. The lower motor neuron differential, acute lower motor neuron differential list depends on the area that you live in. Obviously, if you are in Florida or southern area of the United States, maybe coral snake is a differential that you need to keep in mind. Certainly not in Zurich. But or if you are in Australia, tick paralysis certainly is one that you want to keep in mind. Here, for us, the differentials, the primary differential remain myasthenia gravis, European tick-borne meningoencephalitis, FSMA, although that presents slightly different clinically. Normally they have central nervous system involvement as well. Is not primary peripheral neuropathy. There's a central and peripheral component. So this one can look like a lower motor neuron disease, but certainly is a more complicated process involving the whole central nervous system. And in the summer, green-blue algae. These are kind of the real differential. Botulism, we put them in a list because we like, and we have to because it's in the books. I maybe saw one case or referred and never even confirmed it. So that is something that you keep in mind as a differential. So honestly, for us, the first and most important thing to do is to exclude diagnostically myasthenia gravis and then do electrophysiological studies to see if there are findings suggestive of polyradiculoneuritis. So the clinical signs normally, especially for the acute form, don't leave you waiting for long. They are rapidly progressive. If not hourly, within 12 hours, you see a progression towards flaccid paralysis. And you can have cranial nerve involvement, but the dog is completely conscious. There's no seizure activity, no obtundation. Cranial reflexes might be involved, but mentation is never an issue. Change in phonation is one of the initial findings that are detected. They tend to maintain the tail wag, and but still and then losing it in a later stage, but still is one of those condition where still myasthenia gravis is a big differential for especially the fulminant form of myasthenia gravis. Respiratory paresis or paralysis is due to intercostal and phrenic nerve involvement and exhaustion. These patients get tired exceptionally fast, even in very, very light stress situation. And they can go to respiratory distress with exhaustion quite rapidly. So normally we just assess ventilation. Is never an issue with hypoxia. It's more the hypoventilation that is the primary issue in these cases, just like a cervical disc patient that you need to ventilate after surgery. So that one is the reason why these patients may become critical very rapidly. The in ER is quite difficult to tell them apart, quite difficult to be honest, and is never a definitive diagnosis, at least in my hands. Tensilon test certainly helps, but also we know well that tensilon test can fail. So these are cases that we don't jump on the boat of, okay, definitive diagnosis. However, in the one that present with flaccid tetraplegia and respiratory distress, the good news is that for myasthenia gravis, there's already a pretty solid ground to say it works in dogs to treat them with TPE. So you go ahead and treat them, and probably you're going to shorten the recovery time, while obviously diagnostics and long-term therapy are put in place. But now, if also acute polyradiculoneuritis responds to TPE, then it's actually a good news, because for those that arrive severely compromised with tetraplegia and respiratory dysfunction, hypoventilation, then even if we don't have a definitive diagnosis of what it is, we could put it in an emergency session with TPE and use the tool to stabilize these patients, because as you will see in a paper or in a manuscript, the response time is quite short. We are talking about 24, 48 hours to significant clinical neurological response. So in myasthenia is clear, it happens. We know that sometimes they walk off the table from not being able to get on the table. They want to jump off at the end of a session. For polyradiculoneuritis, I can't say that was the same, but the time frame of very severe neurological compromise to improvement is still a frame of time that is visually tangible. So you don't have to wait 2 weeks to decide, well, should I continue with TPE or not? That makes me very happy, because even if I cannot definitively make a diagnosis of MG, fulminant MG or IP, still, if I recognize there is an acutely progressive lower motor neuron disease with suspect of peripheral nerve neuropathy, then I know that TPE could be the rescue therapy that I need to put in place to stabilize this patient. For acute polyradiculoneuritis, for the one in the Midwest, I don't think anybody calls it AEP, calls it Coonhound paralysis still. Was described in 1954, and it seemed that it was more prominent in coonhound, and following exposure to raccoon, whether it was raccoon fight, raccoon saliva, nobody knows. But anyway, that's why it's called coonhound paralysis, and it was described a few years ago. You know, in Europe, we don't have raccoons, so nope, it's not raccoon saliva that causes it, and we know that unlikely that had a direct association. Maybe there's something that triggers it, but for sure it wasn't a raccoon saliva itself. But the clinical signs are consistent, as I said, with a lower motor neuron tetraplegia, and autonomic function and mental status are normal. The most similar human condition to IEP, to the form of AEP that we see most commonly in dogs, is Guillain-Barré syndrome in humans. It develops rapidly. It is linked to anti-ganglioside antibodies. It activates the complement cascade, and it targets selectively ventral nerve roots and spinal nerves primarily. So that is clinical feature, as well as for the understanding that we have of AEP in dog, very similar pathophysiological basis, although we can't definitely say that it's the same disease yet. The treatment of IEP until now, or a standard treatment, relies on basically waiting. That's the truth. If you ask the vast majority of neurologists, they tell you, yep, yeah, if he doesn't stop breathing and if he doesn't hyperventilate, we keep him quiet, we do physio, and hopefully in 3 to 6 weeks might get better. Adding steroids is not effective to shorten the response time, and IV immunoglobulins may be faster recovery, with a median recovery of 30 days, where the control group in the manuscript that published about the use of those of 75 days. The 75 days, I don't know if they really selected carefully their control, is a very long time, but the 30 days recovery time is certainly something that if you hear a neurologist in a exam room talking to the owner, is a kind of a norm of what gives as an expectation for how long their patient, their dog, will need to be basically supervised hourly and have physical therapy and supportive care and so on. So basically, up to this moment, the therapy for IEP or AIP is quite limited. So we didn't find much that helped them substantially. The issue becomes that inevitably, then you're going to have many cases that are left untreated and probably euthanized shortly after a diagnosis or the rapid progression, because of the estimate of time given on how long, hopefully, they will recover without complication. Now, it's a disease that thankfully doesn't give long-term complication. It's kind of like strychnine intoxication. If you survive it, it's not much injury, or tetanus. There are diseases that thankfully, if you go back to normal, you are pretty normal afterwards. But the problem is the management for such a long time in hospital and out of hospital, limiting the factors. So here are the monsters that we treated. I have to give a little disclosure. In a case series, I did not include one dog, which was the very first I treated, which was a desperate case from their neurology team at North Carolina. It was a Westie. And that was brought to me because after 10 days of therapy, and that one had received already IVIG, steroids, and so on, continued to deteriorate. And from monoparesis went to paraparesis, and then tetraparesis, and then in respiratory stress, the owner was about to say, okay, we're done. And so we treated that dog for free out of me saying, look, I have a paper that says Guillain-Barré might respond. They said, can you do it for free? Okay, we did it for free, and the dog recovered. Obviously, the comments was, yeah, well, you already did 10 days of therapy. I think it's coincidental that he got better 5 days later and probably would have made it anyway. The owner was very happy, and the owner still believes today that I saved, or TPE saved his dog. Probably is dead now. But anyway, I also believe that TPE saved the dog. So when I arrived here and I had a little bit more freedom of choosing when to do treatments or not, and I started with these cases. Obviously, they're not very frequent. So if I had to wait more than 4, I will still be waiting for the 5th, to be very honest with you. So it's not a frequent disease, thankfully. Now that I know that the response is good, even if they were more frequent, I wouldn't be frustrated. I'm far more frustrated with acute glomerulonephritis, to be honest. So, but this patient actually was the very first, was a little Pomeranian that was owned by very exceptionally rich clients from Luxembourg. And they brought us this patient referred by a neurologist that already had under care. In 48 hours, this patient was tetraplegic. It did not have hypoventilation as a presenting complaint, but it was tetraplegic and flaccid. So you still had normal, at least diaphragmatic function. He could swallow. There were no other complicating issue in terms of aspiration or so on. So it was basically the most stable IEP that you can see. This one, by the end of a second session, walked out of the room. So this is him at the end of a session. As you see, he still gets tired, but he walked out of the TPE room out to go pee outside. So this one is a second patient, a fox terrier. And also this one had a 1-week history of progressive weakness. And it presented to us still weak, but by the morning was tetraplegic. So also this one progressed quite rapidly, but the time frame was very different. The other one, over a course of 2-3 days, got to be as compromised to the degree of plegia. This one took 8 days. And simply, we could watch the deterioration over a 12-hour window. And so the neurologist said, okay, good to go. Let's treat him because he seems definitely a acutely progressive polyradiculoneuritis. And this one is at the 3rd session. So we did 4.5 plasma exchange. We will go into the detail, I assume, of the TPE sessions a little bit in a second. But this is at the end. It's interesting that they are not annoyed by my voice, so they actually come towards me. I don't know if they were forced by the leash to be pulled towards me or what. I'm kidding, but yeah. So end of a 3rd session from tetraplegic, 5 days later at that point was walking normally and without even much weakness. This is another case. Actually, this case was owned by one of my assistants, and the dog lived in Serbia, and so they had to fly to Zurich, and that was a little bit of an issue to get through the custom with the dog, but thankfully we were able to get it to the hospital. But in Serbia, was still able to stand. By the time they arrived here was 8 hours from the time that they got on the flight and they arrived here. Even just the stress of the travel, the dog was tetraparetic and with non-ambulatory. And when he arrived to us, probably was also stress-induced, but was hypoventilating already. And is very likely that the hypoventilation was induced by the fatiguing of being stressed during transportation, because he wasn't fully plegic. So it's unlikely that tetraparetic lower motor neuron disease would make you fully unable to maintain ventilation. So I think it was a combination of the two factors. But this is the dog after one single, and this was acute, was a 2 days history of weakness going to paraparesis, tetraparesis, not being able to walk at all, so non-ambulatory, and arriving to me. So it was a 48-hour window. Interestingly, this dog a year before had an episode where he couldn't bark. She couldn't bark all of a sudden. She was like, ah. But within 5 or 6 days, went back to normal. And a year later, instead, progressed to the degree of tetraparetic. We did one single session, and the morning after, the dog was ambulatory. So this is her the morning after the first session, and then continued to respond and remain stable. And then we had one case of which, to save my life, I couldn't find the picture, a Shiba Inu that was presented to us. And in that one, the peculiarity is that the neurologist was quite convinced of IAP, but it could not fully exclude the possibility of myasthenia. So we treated the dog. It responded quite well, but then a week later came back with neurological signs that were worsening towards, again, lower motor neuron. They started pyridostigmine, and the dog got better. But then when we got the antibody tests from California, they were negative. So it didn't seem to be myasthenia, but it could still be myasthenia. We put in a discussion. So I honestly don't have 100% certainty of this one being IAP. Both my neurologists believe there was an IAP and probably simply had only a partial response, or the antibody burden was higher in this patient and he had a rebound, and so he became clinical again and was able to control the clinical signs on his own. And because they are not fully confident that mestinon did much in this case. But as I said, for full honesty, this fourth case is a little bit of a gray zone, simply because there was no 100% exclusion of myasthenia. The efficacy of TPE, as you well know, depends by multiple variables related to what you are trying to remove. Besides the pharmacokinetic standpoint related factors, when we talk about polyradiculoneuritis, the neurological signs appear when demyelination is ongoing. So the patient will start to have neurological signs when there's an inflammatory process associated to the myelin cuffs. And then it progresses, the more the damage is worsening to the myelin, so to the ganglioside. Meaning the course of a disease might have two different phases. One, there is the peracute, where you see the rapid progression, but then there's a sustained phase where demyelination has already occurred. So these nerve roots are naked, and the myelin has to be rebuilt. The response time to therapy varies between these two, and is very clear for Guillain-Barré patients with chronic Guillain-Barré versus acute Guillain-Barré, where the acute forms respond exceptionally well to antibody removal, whereas the chronic form don't, simply because the demyelination process is already to the stage of needing time to rebuild myelin rather than removing those antibodies that are triggering the inflammatory response on the ganglioside and the myelin cuffs. So that is the difference, the peculiarity regarding the efficacy of TPE, independently from the fact that inevitably, speaking of antibodies, there is going to be an intravascular, extravascular distribution of these. The more the inflammatory process is systemic, the more likely the equilibrium of immunoglobulins goes towards 50-50, where there's basically no clear discrimination between fraction that is intravascular versus the fractions that resides extravascularly. The less inflammatory the patient is, the more to have a response, you need to be able to access those antibodies that are causing the harm, obviously extravascularly, unless you're talking about endothelial disease or IMHA, where you have antibodies that are causing harm within the vessel. When you're talking about neurological disease, skin diseases, or so on, you have access, obviously, with the therapy to the intravascular compartment only, particularly with the TPE session, but the ones that you actually want to get rid of are outside the vessel. So the inflammatory state of a patient is a factor, although normally an even distribution of 50-50 among all immunoglobulins involved, so IgG or IgM, doesn't matter, which are the primary targets that we have for the diseases that we treat. We kind of think of a 50-50 distribution, even though IgM having a much larger molecular weight, they tend to reside more intravascularly, and IgG, instead being smaller, tend to reside more extravascularly. These kind of this dogmatic view on the distribution of immunoglobulin doesn't honestly matter much at the clinical table. And for the human patient, the patient is treated with TPE until he gets better. It's not in any way something that targets specifically, oh, now we measured that we remove 80% of your antibodies. They couldn't care any less. If this patient with fulminant myasthenia cannot blink, then it needs another session of TPE. For us, we are, I think, in a gray zone yet, where the cost of therapy and the possible complication associated with treating very small patients, much smaller than the ones that are designed to be treated with the machines and the circuits that we have available, kind of forces us to use some rules. And in the paper, we try to standardize the rules in a way that, at least, although it wasn't a prospective study, as a case series was kind of systematically using the same approach. So this is a formula that all of you know to estimate what is the residual volume of antibodies present at the end of a plasma exchange, whether you're processing one plasma exchange, 1.5, or 2 plasma exchange during that session. You're gonna predict that 37%, 22%, and 14% respectively will remain within circulation, so within the intravascular compartment at the end of that exchange. This formula is a monocompartmental formula, so this assumes no reequilibration from the extravascular space, which for antibodies actually quite holds true in nature, because even in a session of 2 hours, there's no chance that you're going to have a significant refilling or reequilibration of extracellularly located antibody within the intravascular. Sorry, I kept saying intracellular, but I'm meaning extravascular. Please, sorry, I'm tired. Extravascular versus intravascular. So the extravascular antibodies will not redistribute intravascularly to a significant extent during a duration of a TPE session. For that matter, the monocompartmental estimation of how much antibody mass is being removed holds true. For molecules that instead will redistribute rapidly, as it happens with dialyzable toxins or dialysable substances, then the monocompartmental model doesn't work, as you well know. So what we decided to do in our paper is to use the standard 1.5, roughly from between 1.4 and 1.6 plasma volume exchange per session, which will maximize the benefit of removing as many antibodies as possible from the intravascular compartment, minimizing, though, the increase in replacement if we went up to 2 plasma volumes or 3 plasma volume exchange, where, yes, you remove a little bit more antibodies, but then you need to replace twice as much volume that you have removed. So that compromise is the reason why 1.5 plasma volume is the most reasonable. The second reason why we use 1.5 plasma volume per session is because the machine that I use here is a membrane-based plasmapheresis device, TPE device. And with membrane-based devices, even when you have perfect anticoagulation standards, the clogging of the pores within the circuit is inevitable. So the efficiency over time beyond 1.5 plasma volume or higher plasma volume, and again, we're talking about human patients, becomes decreasing with membrane-based TPE compared to centrifugal that basically has a consistent efficacy along the spectrum from 1 to 3 plasma volume. But as I said, 1.5 plasma volume exchange per session is kind of the standard for membrane-based TPE, both for human patients as well as the one that we used in our case series. Here you see the distribution and turnover, the redistribution time, the redistribution fraction or rate of extravascular immunoglobulins in general is somewhere around 3% per hour. Meaning, once you have emptied the intravascular space of antibodies, the redistribution from extravascular to intravascular will go at a rate of 3%. So to reach the equilibrium again, 3 times 24 hours, 25 hours, you're going to have nearly again the new equilibrium or 80% equilibrium. That's the reason why we chose to do Q24-hour session in the vast majority of our patients. So we do one session every 24 hours based on this estimation of redistribution from the extravascular compartment to the intravascular compartment. The logarithmic decay of the residual percentage here is pretty well known, so I don't want to bother you more on this. The sweet spot, as I said, stays around 1.5 plasma volume simply because it reduces the amount of volume exchange. As a poor man estimation, what I always say is about you're going to leave intravascularly 30% with you're going to remove 30% with 1 plasma volume, 63% with another 1.5 plasma volume, and 78% of the total antibody present at the beginning, at baseline. So before you started, with 3 sessions of 1.5 plasma volume each, 24 hours apart, which basically brings down by 80% the amount of antibodies that were within the animal up to that point. Generating antibody obviously is an ongoing process. So if the immune system is still triggering production of antibodies, these need to be kept under control to have long-term response. But certainly the time frame of 24 hours is not enough to regenerate the amount of antibodies that you have removed. Now, for many immune-mediated diseases process, including myasthenia, immunosuppression is still a recommended therapy, or for IMHA and so on, all diseases that you already treat. For IEP, immunosuppression doesn't seem to reduce the rate of recurrence, nor to shorten the recovery time. So actually, we didn't immunosuppress any of these. One received steroids, I think. I don't remember exactly, but we therapeutically basically we rely strictly on TPE, and the response that we had was watched for at least 6 months. Actually, now is a year for all these cases. And besides the relapse that I declared 7 days after in one, all the others had no recurrence and no return of clinical signs, despite lack of any immunosuppression. So this is kind of my estimation. Normally, what I say is with one TPE session, you remove 30% of what is in the body, 63% with 2 sessions, 78% with 3 sessions. That's the reason why also our sweet spot for 90% of cases is 3 sessions of TPE independently from the disease process. And if we have a partial response in some disease processes, we may consider to do a 4th. But if we do not have a clinical response by the end of a 3rd session, which basically is 3 or 4 days, whether we extend the gap and we give a break to the patient because maybe clinically needs a break of 24 hours more. So if within 3 or 4 days we don't have a clinical response, even partial, we definitely don't go for a 4th session. In none of these patients, we went for a 4th session. They were all 3 sessions of 1.5 plasma volume each. Here is the math, the drawing that I always make to my resident to explain what happens in the gap of 24 hours between sessions of redistribution between intravascular and extravascular, with a sort of a constant of distribution between the 2 compartments. And so at the end of an exchange of 4.5 plasma volumes over 3 sessions, you'll end up with 8.7 plus 1.5% calculated amount of antibodies still present. So you have removed about, as I said, 88 or 90% of the antibodies that were there before you started TPE. As I said, IAP is peculiar because it resembles pretty closely Guillain-Barré, where complement activation is a component of a disease syndrome, particularly in the acute form, the acute demyelinating form. And C3 is the complement protein that is primarily triggered. The distribution of C3 is equivalent to antibodies. And so basically you estimate complement protein removal by using the same formula that you will use for antibodies. The issue is, though, that complement gets a recovery of 90% at 24 hours. So the problem of when we target cytokines or complement protein is that the regeneration of these is much faster than antibody per se. And that's why there's a strong debate on the use of extracorporeal therapy for selective cytokine removal. Never mind, it doesn't matter. In this case, complement might be involved, and the reason that removing also complement alongside the antibodies might be the reason why they respond so fast. I can't tell you because I didn't measure complement and I didn't measure antibody removal. So I don't know in the 4 cases that we treated which helped most or at least correlated best with a clinical improvement. But that is the situation. As I said, the background pathophysiology now demonstrated that there are anti-GM2 and anti-GalNAc GD1 antibodies in polyradiculoneuritis in dogs that are detectable and measurable. There's a publication that actually proved the decrease in antibody concentration on JSAP last year. And then there's our publication regarding the clinical response with, as I said, the more targeting the clinical outcome. Double filtration plasmapheresis has a strong advantage in terms of setting. Now we can go into question and answer, I guess, but only because in a large breed dog where replacement volume inevitably are big, the cost of therapy becomes incrementally higher, not because of the therapy per se, but because of a plasma that we need to transfuse the patient back as replacement volume. With double filtration plasmapheresis, you bring down the replacement volume to basically zero or near zero. And so it gives, in face of the same efficacy in antibody removal, a much lower volume of replacement being required with less risk of transfusion associated complication, which, okay, with plasma are not so common, but at least they don't get poofy during the plasma transfusion that they are reacting to. And second, and very importantly, the cost of the session itself. So that's actually the machine that now I use for any TPE treatment in any dog above 20 kilos. The reason is that, unfortunately, this specific device has a large extracorporeal circuit volume that is about 250 mLs. And so instead of doing a full blood priming in such a big volume like this, I will use the pediatric circuit of the Prismax for smaller patients. So that also, because the cost of plasma for a 5 kilo dog is nothing for the replacement. I would say I stop here so we can have some Q&A that maybe is interesting for everybody.
Yeah, thank
So
you,
let's go.
Alessio, for the presentation and for digging into the kinetics of it, which is always interesting. So now we'll open the floor for questions.
This is Cowgill. I had one. Thank you, Alessio, for that very illuminating discussion. We've only had the opportunity of treating 2 of these patients and had very, very similar responses to yours. Within a day or 2, these animals are recovered. But we've had the very difficult task of getting our neurologists to agree to treat them. They feel, well, if I don't bother to treat them, they're going to get better in 3 or 4 weeks anyway. Why bother to treat them when you tell them, well, I can get the dog out of the hospital in 48, 72 hours? That doesn't seem to have influenced them. So I think one of our big goals needs to be to really try to convince our neurologists of the value of plasma exchange in these neurologic diseases. Certainly your manuscript will help that. And also, I mean, if you look at the ASPA guidelines, neurologic diseases are some of the principal diseases that are treated by plasma exchange. And I think if we go through those and try to pick out neurological diseases in human patients that have a similar course or a likelihood of being similar in veterinary patients, that there's a lot of opportunity there for us to expand the indications for plasma exchange in those neurologic diseases. Thank you again for your presentation.
Thank you so much, Dr. Cowgill. I'm gonna admit, you might not see it, but I have goosebumps when I realized that you were attending and you actually commented so positively. So thank you so much. I'm flattered. But yes, I have nothing to add. That's true. That's true. The reason why we wanted to try to go for JVIM neurology was exactly for that reason, because it's very rare that these patients are referred to an extracorporeal therapy unit for treatment, or they present to the ER where there's enough certainty to say, yeah, definitely this is a disease that I can treat with TPE in a center that has both an ER. So inevitably, these patients are diagnosed by a neurologist. And so that's why I selected not an emergency and critical care journal or a human apheresis journal, but a veterinary neurology oriented journal, because I really believe, as I said, I can't prove anything out of 4 cases, but the outcome that I saw, it was unexpected by anyone. Certainly by my neurologist, they came in to see if actually I faked the video on the dogs because they didn't believe that the dog really was walking. So, but thank you so much for your comment.
Well, and I think the same with myasthenia. I mean, there's such a clear indication for treating dogs with acute myasthenia with plasma exchange, yet we're just finding it almost impossible for our neurologists to transfer those cases. They did initially, but I don't think we've seen one in 10 years.
Oh, wow.
Whereas we were very successful in treating those dogs. Our first dog we ever treated with plasma exchange was a myasthenic and was better in 2 treatments.
Yeah.
And I would also agree with you. I think you need at least 4 to 5 plasma volumes in these patients. The same with TPE. I think if you just treat with 1 or 2 treatments, you're unlikely to get a good response, and it usually takes about at least 4 plasma volumes to see that benefit.
Yes.
Yeah.
Yes. I completely agree on this.
And I would echo what you both say, and I would add that even when sometimes we complain that we don't get the referral, it's also our responsibility to bring the evidence to convince our neurologists or other specialties of the interest of extracorporeal therapy. So thank you for this case series, because I think that definitely contributes to us seeing more referrals for that indication.
Thank you.
I do wonder if, again, thank you. That was brilliant. That was amazing. I've got maybe an invitation. I do see a couple of neurologists on the call here today. Is there anything from their perspective, as we're talking about how we feel the strong indication for it, that would be something that would lead them to feel reluctant about pursuing it, recommending it, talking about it, consulting on it, or even starting it sooner than waiting around for it? I don't know if anybody's brave enough to speak up out there. The good Dr. Wood.
I hope they weren't the reviewers.
Yeah, I could give my perspective, which has dramatically changed. I think, I don't want to be defensive of my peoples, but some of it comes from just the exposure, right? So you just talked about how you put it in a neurocentric journal. Fantastic, right? There's, let's say, 50 to 60 really cool things that happen across the 40 journals that we keep our fingers on. And they're interesting, but we don't always connect this case that was here over, and then this other thing, and then 3 more. And it's everything, like whatever, PEG, new methylene blue, all of those spinal cord injury things. And so it's in my journey, which began sort of before plasma exchange was, there was a group at Penn that was doing it. And that was new and was online, and they were trying a few things. And so I think we don't always get that larger world view without actually getting invited to things by Jethro saying, hey, we've talked about it. Like we've had these side chats. He can do it. So I'm again lucky to be at a place that can do it and can have the conversation. And so it's sort of, despite being a neurologist, you have to win over both our minds, but mainly our hearts, right? Like we have to believe that this is the right pathway. And so if I think about how this helps sort of sculpt what we're doing, is that actually you've begun kind of going around and knocking out all these different neuromuscular disorders, right? Because on our end, this is a diagnosis of exclusion that is really difficult to prove until they're dead or better. And thankfully, most of mine get better. Well, most of ours get better. I'm not that good. But the bigger question is, if I were to send an animal out for this, aside from the expense and the, mild risk and all of those things, what happens if I'm wrong? If it's one of these other disorders, would they have been helped? And that's where that worldview is really cool, because slowly you've just been like hammering on each one. I don't know who Dr. Calgill is, but like it seems to be something that originally I was presented as just for myasthenia, but not other things. And then it's now like polyradic and as well as myasthenia. And so as the number of diseases that get helped by this coalesce and they have overlapping clinical signs, all of a sudden it goes from like experimental or feel good or maybe we should try, and it begins flipping that script to being like, great, I've boxed them into neuromuscular. Awesome. I call Jethro and say, is this a case that we could do this in? And it sort of allows us to be a little more proactive. Because I mean, like if I could bust out those videos of dogs running around day 2, I'd be a hero. So I think there is that like combination of we're worried about the downside, we're worried about the risk. We don't always live somewhere with groups that we know of. and probably more than that, that we truly trust, like that's where we're going. And how the cases come in, if I have to get to the very end to know what it once was, I'm less likely to do something. Whereas if it's like, okay, no matter what it is, right? If it's a cervical dog and I shove it in the MRI, if it's cancer, we have surgery. If it's a disc, we have surgery. If it's ANP, I don't have surgery, but now we know we don't need to do surgery. Similarly, neuromuscular has always been this sort of black box, and we've played around with our neurodiagnostics, trying to sort of test and say, can I box you in closer? It takes me 2 weeks to get a titer back. What can I do in the interim? Well, ta-da, you've shown us what we can do in the interim. Even if I don't know exactly what it is, I've helped the patient. That's my worldview, just one neurologist.
Yeah.
That makes me
And I
very,
think
very
I think it
happy.
echoes also something is just like, and I think we've all been through that for IMHA cases. Is like my best referring internists right now are the one that I've known since they were residents and rotating with us in the unit, and they saw these dogs respond. And it's just like if you see it, then you believe, right? So even more so than a publication. And again, I think yes, when you see those dogs like running around day one or day two, just like the myasthenia dogs, then your neurologist don't doesn't need a publication anymore, just believes, right?
Yeah, and I think other targets, neurologic targets that are very, very commonly treated in human patients would be encephalopathies, myelopathies. Schizophrenia now is treated with plasma exchange in human patients, and what is that disease? You wouldn't have thought that there was some humoral component that was involved there. But a whole variety of just encephalopathies and myelopathies, peripheral nerve disorders, Zika virus, uh, uh, myelopathies, and peripheral nerve disorders, all been convincingly shown to respond very, very acutely to plasma exchange. So it'd be very good for those programs out there doing extracorporeal therapies to just have a sit down session with your neurology group, go through the ASFA guidelines, looking for similar disease in animals that would likely be target candidates for plasma exchange.
Thanks for that, Alessio. That was great. I had the pleasure of being involved in that case at AMC where we looked at the antibody reduction and rebound in that one dog that responded, and seeing the neurology team, believe in it, like kind of like you've alluded to, within 24 hours the dog was, walking again, and 48 hours, much better, and then we're kind of normal dog within a few days, honestly. And kind of they're all excited about it. So with the new publication too, I sent it to them, and hopefully
Yeah.
we'll be able to do more cases. But it was also curious if anybody here has had experience treating any of the like MUEs or MUOs that are kind of more refractory to treatment. I've had a couple of clients reach out about like meningitis or immune-mediated meningitis cases, and whether it would be an option for ones that are refractory to standard therapy, or they're kind of been treating and they have frequent relapses. If we should potentially consider those like some of the IMHAs that sometimes we treat when they're relapsing, and then they kind of go into remission and kind of remain in remission for much longer periods of time. I don't know if you've had any experience with those cases or not.
That's quite interesting that you're bringing it up, because we are in the process of submitting a grant for treatment of limbic encephalitis in cats. That seems, for what my neurologists tell me, becoming more and more prominent as a likelihood to be having an immune-mediated process behind, and an inflammatory process associated to it. So that one is certainly something that we're going to do. As Dr. Kaugel said, I was contacted by a schizophrenia managing a schizophrenia specific clinic in Germany, and asked me if do we see schizophrenic dogs? Well, I showed him this picture of my dog, and he's like, yep, then you see him. Would you be interested in a project to treat? Then obviously it was a little bit of a joke, but they are also looking into senile dementia as well. and they are very, very interested in seeing if they can lower the progression with therapeutic plasma exchange. So the array of neurological disease where it seems that an immune-mediated process linked to antibodies is plausible or confirmed certainly are an important target for this therapy. And for sure, myasthenia, there's no doubt. There's no human neurologist that will tell you I treat anyhow else a pure myasthenic fulminant form in a human or a pediatric patient. They will get on TPE. So the only thing I would add on myasthenic, we have managed a few cases. So probably I need to do a case series of those two. But the issue that I had is in 3 of these patients that presented to me referred because they failed initial management, medical management. When they arrived with aspiration pneumonia to me and I treated them, they rapidly deteriorated from the pneumonia standpoint, going to ARDS, so acute respiratory distress syndrome. And that is the reason why I tend to refrain to select a patient as a good candidate with myasthenia when I see clinical evidence of aspiration pneumonia, because I don't know if is the plasma exposure, basically the massive transfusion that they receive in plasma as an exchange being a factor. Even when I try to limit it to the minimum, if I say I do only 30% replacement because they are normal proteinemic and I don't need to give much, still I had 2 of these with minimal replacement deteriorated to ARDS and 1 with a standard replacement of 50-50 between crystalloids and plasma, also at a respiratory distress syndrome, despite the fact that neurologically they got better. So I had still to ventilate these patients because of a respiratory disease primarily and no more for the neurological. So there was no more advantage. Again, it's just a case exposure and bias now. And so maybe I'm just afraid that I need to be a little bit more bold. But as Carsten Ben used to say, you're bold enough. So maybe I should also take these as a halt and point to think about before continuing in that direction with those specific patients where there are clinical signs of respiratory dysfunction, not related to the neuromuscular disorder, but because of a pulmonary involvement by the aspiration. And so that is, I don't know if any of you had similar experiences with myasthenia with aspiration, confirmed aspiration and clinical. So not just radiographic evidence, but these patients needed oxygen support. These 3 that I treated got worse. And so now I'm a little worried.
We've treated 8 myasthenics, none recently, but in our original series of 8, about half of them got resolution of the megaesophagus, and about half of them didn't over a long period of time. I would be suspicious that your respiratory complications were primarily aspiration, but again, about half of them, the megaesophagus will resolve. We've had some that resolved in a couple of weeks.
Yeah. When they only have neurological involvement with megaesophagus, I think is especially if they're rapidly progressive, I tend not to hesitate. We haven't had one in at least 3 years here, so that's a little bit of a pause. But when I had those with respiratory signs, so hypoxia from pulmonary disease, then I had a very poor response from the respiratory standpoint, and that's why I'm a little bit worried about treating those. But all other myasthenia cases that are rapidly progressive or severely compromised, to me, is a no doubt that is a recommended therapy. I have to say I'm lucky because my neurologists here are quite proactive. So that was good. But also in North Carolina, I didn't have a bad experience. So they were also quite enthusiastic and saying, okay, we know that if we do our normal thing, it will take a very long time to have a response. And let's give it a try in this way. But I think it's very important that we bring up as much information as possible and make it readable to a public that we have as a target that represents not our own audience, because we're kind of convincing ourselves it's not, doesn't take much, but speaking to a public that is outside our little family group or retreat group is quite important. So
we treated myasthenia about a month ago here, and a large breed mixed dog, and very weak for sure. And we convinced neurology to treat. The neurologist even stayed late to watch us take the dog off the machine, I think twice, and embarrassingly, he did not get up. But the big thing that our criticalist was jumping on was that he hadn't developed megaesophagus yet. Like, let's get up on this. And of course, when I went to go get the dog out of the cage, that's the first time he started to develop a wet cough. So I was like, oh boy, here we go. This isn't going to work, because yeah, huge complications if aspiration is present. It's going to get in the way. And however, luckily, we did that first treatment. I think we were only granted to do 2, but he never progressed to megaesophagus, and he did not get aspiration pneumonia. And he went home the 3rd day of hospitalization. He just was progressing very, very just slowly, slow incremental steps. We, of course, did not have the giant reveal that we wanted to say see to the neurologist. And of course, people are like, well, maybe he would have never progressed to that or whatever worked. But I'm very happy that we caught that in time.
I'd be curious, since the plasma exchange is fairly non-selective, and we know that there's so much crosstalk between the inflammatory cascades and the immune cascades, is, what else is being removed that, that may be negative feedback loops that then is allowing that pulmonary inflammatory cascade to get out of control? Or have they developed a secondary infectious component to it that we're then undermining a bit by removing all the antibodies?
yeah, as I said, for the acute form of Guillain-Barré, it's clear that there's a component of complement being largely involved in the acute process or the acute clinical presentation, alongside with the antibodies. And in the serieses that are available to us, there's a definitive assessment of a reduction of both at the myelin level, so at the nerve ending level, as well as the circulating with the therapy. So probably is a combination of both being removed, with the downside of complement or other cytokines that are produced by inflammatory cells or any cells at a rate that is much faster than anybody. So you might have a rapid response, but probably a very fast relapse, or more likely a relapse, if you're relying just on removing those. So it remains that antibodies are the primary target, because the response is consistent with their decrease circulating and extravascular or topical, meaning organ selective concentration, and the response then is sustained as well. But yeah, for sure, there's a much more complex interplay than just a single little antibody that we remove and we measure.
All right. Well, it seems like we're already like almost 15 minutes past the hour, and we still have a huge group of people around to listen. So that was a great session. Thank you so much for the presentation. Thank you for the paper and the great discussion as well. I think we probably need to wrap that up, even if I mean, I think a lot of us could stay another hour just like chatting about it. But we need to put an end to it today. So thank you so much for the attendance. I will be happy to see you back in 2 weeks. There's no predefined topic for the next session yet, so it will be more of an open discussion. So please bring cases, bring questions, experiences that we can discuss. But definitely, I'm really happy with those meet the author sessions and having special guests. I think it brings a lot to our community, and we'll definitely try to organize more of those.
And just a quick note as well. Again, amazing discussion, presentation, everybody else's input. These sessions are recorded and available. I put that in the chat. So spread those around to all of your neurologist friends and everybody else. Alessio, wonderful. Thank you so much. And on the GME discussion, I have a student. Sorry about my sheep. I have a student that has a presentation prepared for us down the road. So we'll circle back around to that. And thank you again, everybody.
Thank you so much, everyone. Thank you,
Have a good
Cedric,
day.
Jethro, and thank you, everybody. Ciao.
Bye.